Hey everyone, good morning. Let me know if you can hear and thank you, Sonia. Glad to have you guys here. Start in just a couple minutes, but please put up any questions you have. We talk about those. Put up. I don't see any questions yet, so hopefully everyone caught up on all the oncology stuff. But we'll get through the rest of it. And yeah, I'll address that in just a moment. I'll get it on tape. Good for everyone here. So I'll go ahead and get started. All right, so I got recording going here. So Savannah's asking about supplement with folate while they're on a folic and as an antagonist. You'll typically see this more so with like rheumatoid arthritis, where they're getting smaller doses of methotrexate in order to kind of keep their inflammation sort of in check. And so they'll get folic acid, usually like, I don't know, 1 milligram a day or something. It's probably not going to do a whole lot of help just because that's what methotrexate does, is block the utilization of folic acid. So I don't know if it's going to do any harm. It's probably it may help some of the healthy cells, but it's one of those things where it's like um, if you truly need recovery from giving like larger doses of methotrexate, for instance, like for cancer, folinic acid or leucovorin is really the thing that you need to give in that case. There, folic acid wouldn't really do a whole lot of help in that case there. So just remember to keep that delineation between folic acid, which is the inactive form, to folinic acid, which is leucovorin. That's the active form that you're looking for there. Yeah, so probably not going to be huge help, but probably not going to harm anything there in those cases there, because the methotrexate still sticking around. It's still blocking the utilization of that folic acid. So that makes sense. Okay, so don't worry, no worries. Don't care when the questions go up. You can ask me whenever you like. So we were talking about the anti-metabolite drugs. We talked about the false nucleotides and how they can act as like chain terminators. We talked about some that work more so to block the production of the nucleotides. Now we're switching gears there, and more so focusing on the microtubule targeting drugs. And so microtubules are really important because they do things like provide cell structure, but they also help during mitosis to actually pull the chromosomes apart. And so if you can't do that, then you can't complete mitosis. And so that's able to basically stop reproduction of the cells. So if you recall, we talked about how some drugs are cell cycle specific and some that aren't. We talked about antimetabolites, they're affecting DNA production. So it would make sense that those are more so acting on the S phase of mitosis or of the cell cycle. And here we're going to see these are working on the M phase or on the mitosis phase here. And we have two primary groups of drugs that affect this, including the taxanes and then the vinca alkaloids. This is a picture of a Pacific yew tree. This is actually where we get taxanes from, or at least where we originally got taxanes from, which is kind of interesting. Probably don't want to eat this plant if you see one. But we have two drugs here in the taxanes called paclitaxel and then docetaxel. And basically, these will allow the microtubules to form, but they prevent them from being broken down. So if you're not able to really process these fully, it helps to inhibit the mitosis phase, and it basically cannot. These non-functional microtubules that are going to prevent mitosis from occurring. So all the chromosomes will be lined up down the middle, but they can't really separate and produce the new cells. Which that will trigger off apoptosis and kill off the cell. So what we're going to see here in terms of toxicity, myelosuppression for both of these, that makes sense. Most of these drugs are going to cause some degree of myelosuppression. Docetaxel causes fluid retention, so it may not be good for someone with like CHF as an example. And then paclitaxel tends to cause neurotoxicities. This will typically be manifested as peripheral neuropathy, sort of that stocking glove sort of distribution that we talked about. So it's really distal peripheral nerves are going to be affected. So things like paresthesias and tingling, things like that, you're going to experience in the toes and the fingers primarily. And you can see some hypersensitivity. These are likely enough to cause hypersensitivities that we oftentimes need to pre-treat with corticosteroids. So we can give them things like prednisone or dexamethasone prior to giving these drugs, and that will help to limit some of the anaphylactoid sort of reactions that you can develop there. So we'll see that a lot of times you need to pre-treat for some of these medications, and this is one of those examples here. Next, we have the vinca alkaloids. This is actually a picture of the periwinkle plant where we get the original vinca alkaloids from, and we have three drugs in this category, including vincristine, vinblastine, and then vinorelbine. And so instead of promoting microtubule formation, these actually prevent the formation of them. So that's kind of the difference. The taxanes are preventing the breakdown of microtubules. The vinca alkaloids are preventing the formation of the microtubules. So ultimately, you get the same effect, is that mitosis cannot continue. In terms of toxicities, again, myelosuppression is going to be big about this one. Vincristine itself, which is kind of funny because it gets abbreviated as VCR, which I'm assuming most of you are too young to ever actually used a VCR, but those are things we used to watch movies on back before DVDs and Blu-rays. This can actually cause a neurotoxicity again in that hand-foot distribution, as I mentioned. But also, this can actually cause damage to the enteric nerves that can lead to things like ileus and constipation. I've seen a few patients to where we were not able to give any more vinca alkaloids because the constipation they got from it was so severe. And again, it's not like an opioid where you can remove it and then the effect's gone, but this can cause permanent issues for these nerves here. One thing to note with the vinca alkaloids is that they are fatal if given intrathecally. So if you were to give this through through the epidural sort of line, this could potentially cause death for the patient. And so, you may ask, like, well, how would you accidentally give something intrathecally? The issue is that oftentimes we give these medications concurrently with drugs we are giving intrathecally. So we may give vincristine IV and then give methotrexate intrathecally in order to both attack centrally and peripherally these cancer cells. And so there have been mistakes where they've gotten mixed up. And so this is one class you absolutely cannot give intrathecally because it will kill the patient. These are also strong vesicants. And so when I say vesicant, it basically means something that if you were to give this through an IV and then that IV is blown for whatever reason, and all of a sudden the drug is now starting to be given to the local sub-Q tissue instead of in the vein, you're going to see some strong tissue irritation and tissue necrosis, and so these vesicles will form basically because the drug is so harsh to the tissue. And so that's a big deal because it can cause permanent damage, potentially disfigurement. And so that's why I always want to make sure that we have really good established IV lines when giving these. A lot of patients will have ports that are placed that have sort of like a semi-permanent sort of central venous axis. And that can be helped to get around that. So a lot of places will have protocols set up for, it's called extravasation basically, for drugs that are dangerous when they are given outside of the vein into that sub-Q tissue. So we've seen a few examples of this already. So for instance, like phenytoin back in the neurology section, called that purple glove syndrome. We'll find a few more examples here as well. And so it's a big deal. So be aware of which ones are kind of the vesicants, because that can cause pretty big damage to your patients. And, nurses may call you and say, what do you want me to do about this? And always look up the protocol, because some drugs require heat, some require cold compresses, some require certain sub-Q drugs to be given. So I'm not going to get too in the weeds on that one, but just know that which ones are the strong vesicants. And this is just a picture of an example showing you kind of the different effects that your taxanes versus your alkaloids might have on the microtubules versus something like colchicine, which we saw back in the rheumatology section for gout, can affect the microtubules as well. So those are kind of the three big microtubule acting drugs there, or classes of drugs. Next up, we're going to be looking at our topoisomerase inhibitors, and you can think about these working the same as the fluoroquinolones like levofloxacin and ciprofloxacin. These are going to be working on topoisomerase enzymes. We have two main ones. We have 1 and 2. I'm not going to get in the weeds and expect you to know the difference about which drugs affect 1 or 2. Just know that they are affecting topoisomerase. And that enzyme basically helps us to cause single or double strand breaks in the DNA to allow it to unwind. So that way things like DNA polymerase can act on it. If you inhibit that enzyme, basically, you're going to cause damage to the DNA, can cause mutations, can eventually lead to enough damage being done that the cell says that's enough and triggers off apoptosis. So again, it works just the way that the fluoroquinolones do, just more specifically to our topoisomerase. And so we're going to have 3 classes here. We're going to have the epidophyllotoxins, we'll have the anthracyclines, and then the camptothecins. Or the 3 classes here that inhibit topoisomerase. This is a picture of the mayapple plant. And again, I don't care if you know what plants these things come from. I always like to illustrate when we have like natural sources for medications, I think is pretty cool. For the epidophyllatoxins, we have 2 drugs in this category here, including etoposide and then tinipicide. And basically, these will bind to topoisomerase 2. And by inhibiting that, you're going to see that you're going to cause more strand break damage, basically. You're going to cause more issues because, again, it can't reseal that DNA back together as well, so that causes further damage. These can also affect the microtubule to some degree, but I bolded the topoisomerase because I want you to know that's the main mechanism of action here. And for these, again, dose-limiting myelosuppression, nausea, vomiting, that's pretty much ubiquitous amongst all these drugs here. And you can cause some alopecia. So not all cancer drugs will make your hair fall out, but some are more likely to than others. And this is an example of one that causes more alopecia than maybe some of the other ones. Next, we have the anthracyclines. We have a couple of drugs in this category, including doxorubicin, daunorubicin, and the mitoxantrone. I put the picture here of daunorubicin because I think it's kind of interesting. If you ever see like a red IV bag on a patient, chances are it's probably one of these drugs here. So it looks like almost like wine that you're giving the patient because it's so red when you're administering it. And basically, these are going to help to inhibit topoisomerase. It can also do something called intercalation. It's a fun word to say. but it can intercalate into the DNA. And so if you notice here, the drug sort of has a planar sort of structure, and it's basically is able to insert itself into the DNA and causing disruption or causing sort of a structural malformation that kind of causes damage to the DNA and eventually can lead to apoptosis. It can also cause free radicals to form, which are reactive oxygen species that can denature proteins and DNA and all kinds of stuff. So that can be some of the damage that it can do to cancer cells, but we're going to see that it kind of cuts both ways in terms of our healthy cells. So with the anthracyclines, yeah, it can cause alopecia. Yes, it can cause myelosuppression, but the big things to note here include cardiomyopathy and potentially can cause CHF. And so, interestingly, with these drugs, there's actually a lifetime max dose that the patient can get. So, once you hit your lifetime max dose, you're unable to give any more of that drug ever for that patient, which is rare that you see that with medications. Also, want to make sure you're doing your echoes both at baseline and at follow up. So, you'll do them on a routine schedule to make sure that you're looking for changes that may indicate that the patient is having more sort of structural damage than what should be apparent with the dose that you've given. We can see this because basically the heart is not able to really detoxify those free radicals as well as, say, other tissues, and so the heart tends to be particularly at risk here as opposed to other organs. And so that's one of the big things we note. One of the ways that we can try to prevent this and try to help out the heart is to give an antidote called dexrazoxane, or Zenocard's a brand name, and this acts as a chelator. It'll bind, basically bind to iron, and allows for detoxification of these free radicals, so sort of a antioxidant almost. And so by doing that, it helps to sort of save the heart. And so we'll see this done usually concurrently along with anthracyclines, and helps to save that heart tissue. Interestingly, other things you can see here is when you're giving that really bright red medication to the patient, you can actually end up seeing red discoloration of the urine and the sweat, which, certainly you want to warn your patient about if you're going to cause changes in their, excretions. But also that can lead to things like staining of like their sheets. Like when they go to sleep, they may, you sweat a little bit at night. And you can see like red discoloration of the sheets. That could be worrisome. You can see things like laboratory tests that rely on colorimetry, or it can be affected because they rely on color to be able to determine lab values. That can affect certain ones there as well. And these can also be really strong vesicants. So now this is the second group we've seen, the vinca alkaloids, now the anthracyclines that can be acting as strong vesicants. So something to note as well. And then we have the canthocecans, which include irinotecan and then topotecan. Again, they're inhibiting topoisomerase. I don't really care that it's one or two, just know which ones are affecting topoisomerase, okay? This one's kind of interesting because they can block, especially irinotecan more so than topotecan, can inhibit the actions of cholinesterase. So cholinesterase is an enzyme that breaks down acetylcholine. By inhibiting that, you're going to see way more acetylcholine around, which means you can see a lot more activity on the muscarinic receptors. And so what happens when you activate muscarinic receptors in the GI tract? You're going to see a lot of diarrhea. So again, diarrhea is not uncommon with cancer drugs, but in here you're going to see very kind of very watery, profuse diarrhea with these patients here getting irinotecan. So something where you may even give it with certain antidiarrheals like loperamide or diphenoxylate or something like that. So that's one thing to note. And again, this is also another one that tends to be more likely to cause alopecia here as well. So pretty interesting. And again, a lot of times the adjuvant medications are just as important as the cancer drugs we're giving because the side effects can be so severe for these medications. So next up, we're going to see we have the alkylating agents. And this is a pretty broad class. And these are some of the oldest ones that we have here. And these are certainly going to be non-cell cycle specific. These are pretty non-discriminatory against what cells it's going to hurt. And so this will be affecting your healthy cells as well as your cancer cells. And so these drugs tend to be pretty harsh in terms of side effects because they're not really that discriminatory in terms of what cells are going to hit. And I'll show you why that is here in just a moment. Interestingly enough, some of these are actually derivatives from mustard gas that was used back on World War I, which is why I put this picture here, some kind of old like kind of, I guess not propaganda, but some old war art that was talking about, hey, if you smell garlic, you're in the middle of the trenches and you smell garlic, that's not a good sign, because it could be mustard gas, because it actually has that sort of horseradish, garlicky kind of smell to it. Could be a bad sign. It says, hey, put your gas mask on. These are one of the oldest classes I mentioned here, and we've been using substances like this since World War I, as I mentioned. So what these drugs do basically, though, is they will covalently bind to alkyl groups in DNA and also proteins. And so again, it doesn't have to be in the S phase, the M phase, anywhere that's non-cell cycle specific, but it's going to cause binding to these different alkyl groups in the DNA. And it will then cause issues in terms of like causing the strands of DNA to bind together. So interstrand breaks that can happen here, or interstrand bindings. Intrastrand bindings can happen, where actually within the same strand of DNA can happen. And just wreaks total havoc in the cell, leading to so much damage it's going to lead to cell death. These tend to be cytotoxic, meaning they're going to be hurting healthy and cancer cells as well. They can be mutagenic, meaning they can cause mutations in the DNA, leading to potentially its own cancer, right? So it sounds counterintuitive, but just like any antiarrhythmic drug can cause arrhythmia, a lot of these cancer drugs can cause cancer because they cause mutations in the DNA. Teratogenic, myelosuppressive, I mean, just really nasty all around. And also can lead to pulmonary fibrosis. So certainly lung function tests are something you want to monitor for as they're receiving these medications here. So the first group that comes out of this is the nitrogen mustards, and again, it's based off of mustard gas, so makes sense on that. And again, I probably wouldn't want to put this on any hot dogs or anything like that. This might be a little bit harsh, but it includes cyclophosphamide and then ifosfamide. And again, these are used to treat all types of cancers, because again, they're very non-specific. Whereas with something like, say for instance, like vinca alkaloids, they're affecting the M phase. Like those are only going to be affecting cells that are actually in the M phase, which are more frequently cancerous cells. But these can really bind to any cells. It doesn't have to be actively replicating. And so you can see here how that kind of happens. Again, I'm not going to get super in the weeds in terms of the chemical process here, but you can see how the nitrogen mustard can cause sort of these DNA crosslinks. And when you do that, it's a covalent bond. The DNA polymerase can't really deal with that, and that can eventually lead to the cell death that occurs there. So some of the toxicities which are going to be notable include things like it can actually cause this toxic metabolite to be formed called acrolein. And acrolein can lead to hemorrhagic cystitis, so it can actually see damage to the bladder, it can see blood in the urine, and to prevent that, we can actually give the antidote called Mesna. It can actually bind to and inactivate the acrolein. The other big thing too with these is that you typically want to give pretty vigorous hydration with these drugs here to make sure that you're kind of flushing things through as quickly as possible. So it's not uncommon these patients will get, fluids at like 2 times normal maintenance rate. They could be getting, a quarter of a liter an hour, basically, just to try to keep the kidneys nice and perfused. Other things you can run into include things like CNS toxicity. So you can actually see encephalopathy and mental status changes, more so with like ifosfamide than cyclophosphamide, but it can happen. You can see renal toxicity. You can see myelosuppression, which can be pretty severe and can be medication limiting, meaning you can give any more meds until the patient has had time to recover, and tons of nausea, vomiting. The alkylating agents tend to be much more harsh from a metagenic potential than some of the other ones we're seeing here. As an example, for patients getting like vincristine, some patients don't even need any antiemetics. They do just fine without maybe a dose of Zofran. Some of these alkylating agents, we have to give 5 or 6 medications just for the nausea, vomiting. So that's how much of a change that can be, and I'll have a slide that kind of talks about that just a little bit later on. The next group within the alkylating agents are the Nitrous Areas, including carmustine and then lomustine. These are actually kind of neat because they're actually used to treat brain cancers due to their lipophilicity. And so you see here, there's one that has carmustine called the gliadel wafer. And so this is actually a picture of someone who had a brain tumor removed. And this is kind of demonstrating how you can use multiple modalities together to get better kill for those cancer cells. So if you have a brain tumor, yeah, you want to probably cut that out. It's going to be the best way to get rid of all those cancer cells at once. But it's impossible for the surgeon to know, did they get every single cancerous cell there, right? And you assume you didn't. And so what you can actually do is place these wafers here and along the borders to make sure that you get any cancer cells that might have been left behind. These can then be removed later on. So pretty cool. You can actually Google some videos to see when to actually place, and it's pretty wild. These can also be used to prep patients for bone marrow transplant because the myelosuppression that the nitrous areas cause is very severe, possibly even fatal because they just have no immune system left over, basically due to how severe the myelosuppression is. But basically, what you'll also see here too is that the nadir, meaning the lowest point that their white count's going to get to, can be delayed up to like 4 to 6 weeks and can last for like up to 2 weeks. So this makes sense how you'd use it for bone marrow transplant. You're trying to wipe out all those cell lines as best you can to get them prepped up so you can transplant the new bone marrow cells. But if this is not what your goal is for other patients, then this again, it can be potentially fatal. So the nice thing here with these gliadel wafers is it's working locally versus giving it like systemically, which you can run into more issues with. So pretty nasty from that standpoint. I think it's going to have all the similar side effects like we saw with the other, with the nitrogen mustards. Next up, if your patient has like really good insurance, you can use the platinum analogs. Kidding, we use this for all kinds of patients. Insurance or not, but they are platinum based. You can see here they have kind of a platinum core, and can lead to these inter and intra-strand sort of bindings here, which just again wreak total havoc on the DNA, causing damage. 3 drugs in this category, including cisplatin, carboplatin, oxaliplatin. If it has platin in the name, then you probably know it's a platinum analog. And again, same mechanism as all the other alkylating agents we've seen so far. In terms of toxicity, these tend to be pretty rough on the kidneys. So we give really vigorous hydration with just normal saline, and that was usually good enough to keep patients, nice and hydrated and prevent that. This can also lead to things like ototoxicity, so hearing damage, peripheral neuropathies, and these do carry a little bit higher anaphylaxis risk than you see with some of these other ones. And then in terms of nausea, vomiting, like these are at the top of the list. So these are really severe. These are cases where we may be giving patients, a dose of Ativan prior to when they get it. They're getting Zofran, they're getting aprepitant, they're getting dexamethasone, just all these drugs just to try to prevent the nausea, vomiting. And you'll see that these drugs don't just cause nausea, vomiting when they get the drug, like the actual infusion, but they can also have sort of a delayed phase over the next 48 hours that can lead to just severe intractable nausea, vomiting. So different ways we can treat that, which I'll talk about a little bit later on. It's a couple of different alkylators as well, including dacarbazine and then temozolomide. Again, you can see the mechanism is roughly identical. It's just alkylating the DNA, causing further damage there. Again, nothing specific in terms of toxicities here, pretty similar to what we've seen already. Busulfan's kind of interesting. While it is pretty similar to the other alkylators, this one its claim to fame is pretty severe pulmonary fibrosis that can happen here. So people talk about busulfan lung that can develop from this. So again, PFTs are going to be absolutely necessary to track both a baseline and then a follow-up to make sure they're not having significant damage, and that may lead them to stop taking it altogether potentially. Okay, so those are the main sort of like traditional chemotherapy drugs. Again, depending on what type of patient you're dealing with, you may not see these ever, or you may see them all the time. It really just depends. But again, if you're working in family medicine, internal med, urgent care, ER, you'll see these patients coming in to see you for maybe non-cancer related things, but you still want to know what drugs they're receiving and what those drugs might be doing that are influencing what you're treating, whether it's their diabetes or hypertension or anything like that. So those are why it's so important to be familiar with these drugs. So at least when you see it, you can recognize, hey, that's a cancer drug. I should probably look this up to see what's going on here. So a couple of miscellaneous therapies we can use here, including hormones. We know that hormones can be potent stimulants on cancerous tissues like prostate cancer, breast cancer, endometrial cancer. And so if we can use drugs that will block the actions of these hormones, then that can be really useful to try to limit one of the major sort of growth factors that would be seen to promote these cancer cells. And so there's lots of ways we can do that. So for instance, with corticosteroids, we can use things like dexamethasone or prednisone to prevent white cells from reproducing. That might be really useful for things like leukemias, right? And so you may see patients who on their roadmaps are getting dexamethasone or prednisone every single day. And then on, say days 1, 8, 15, whatever, they're getting, methotrexate or vincristine or something like that. So again, you're going to see a lot of combo therapies here to try to maximize their toxicity while preventing toxicity to the cancer cells while minimizing toxicity to the patient's healthy cells here. Corticosteroids are also really nice because they can also be used for nausea vomiting. They do have some natural antiemetic actions as well that can be very useful here. But of course, all the normal side effects still apply. So things like altered mental status, hyperglycemia, fluid retention, weight gain, all that stuff's still going to happen. But again, we're using it for this very specific purpose here. So normally what you're going to see with steroid hormones is that they can bind to response elements in the DNA that usually promotes growth of the cell, either replication or production of new proteins and things like that. So if we can remove that factor, if we can remove, for instance, the stimulant for the tissue to grow. So for instance, with like prostate cancer, if I can get rid of testosterone or DHT, that's going to help to limit how much that prostate is going to grow, and those cancer cells are going to have that stimulant to reproduce. So as I mentioned, we can use glucocorticoids to suppress white blood cell production. That's one way we can do it. We can also use anti-estrogens for things like breast cancer, uterine cancer, anything that's responsive to estrogen. And then particularly for anti-androgens, that's going to be more so with testicular and prostate cancer. So that makes pretty good sense if you know what the sex organs are and what they respond to typically. So some ways we can do that, to ways we can interrupt these hormones include things like what we call selective estrogen receptor modulators or estrogen partial agonists. These are called SERMs. Sometimes you'll see. And here's an example of one called Nolvadex. I didn't talk about too much in the OB-GYN section, but one thing you can see here is that this is useful for breast tumors. And why we call them SERMs or selective estrogen receptor modulators is that you can see that these drugs can act as agonists in certain tissues and antagonists in other tissues. And so that can be very beneficial because, if I have a patient who has breast cancer and I try to cut out all estrogen activity from them, they're going to have a really rough time in terms of like menopausal symptoms. You're going to see things like osteoporosis that can develop here because that estrogen is really useful for a lot of other things than just cancer that it's promoting. So by trying to block some of that in certain tissues like the breast tissue, that can be really important while you still get some agonist activity elsewhere, which is needed. So you can use this as an example for some women who have a strong family history of breast cancer, because this is so strongly genetically linked that this might be used as a preventative for those patients there. But again, what kind of side effects you're going to see? Well, typically a lot of things that are related to like menopause, right? So you can see things like hot flashes and whatnot. But we can see some agonist activity in other tissues. So for instance, it acts as an agonist in the endometrial tissue, right? That means if they still have a uterus, they still have endometrial tissue, you can cause cancer there, right? So maybe not the best drug in terms of that. But if they have a history of a hysterectomy, this might be okay, right? You also see positive effects on the bone and in the liver in terms of cholesterol. So again, that is trying to mitigate some of those the effects if you just removed estrogen completely, right? Because we certainly have drugs that can do that. Raloxifen's a little bit nicer of a SERM, I think, overall, because it can still have positive estrogen effects in the bone and the cardiovascular system. But here you see it's going to be used as an antagonist in breast tissue and the uterine tissue. So if you had a patient who had osteoporosis, they're postmenopausal, but they have a strong family history of breast cancer, like this might be a really good drug for them because it can help to block, the estrogen effects in the breast tissue, but still act as an agonist in the bone, right? That's why you see a lot used for things like osteoporosis potentially. Now, if I just wanted to get rid of all the estrogen entirely, then I could use something like anastrozole and letrozole. Here we're going to see the side effects are going to be a lot more severe because we're dropping estrogen levels pretty significantly by blocking the activity of aromatase. So if you can't convert testosterone into estrogen, then your estrogen levels are down, and that enzyme is mainly aromatase that does that. But as you might imagine, you're going to see a lot of side effects related to having all this extra testosterone around. So things like, you may have male pattern sort of like hair growth. You may see like, hair growth on the upper lip. You can see menopausal symptoms like, hair thinning and hot flashes and all of that. So in some cases, if patients can't utilize a SERM for whatever reason, then you could utilize an aromatase inhibitor, right? So again, it's all like a balance between side effects and the toxicities. The side effects versus the benefits that you're getting. Exemestane is an example of an irreversible aromatase inhibitor that's even stronger. So estrogen levels plummet by about 90%, and again would be more severe from a side effect standpoint, but are useful for patients who are not really responding to much else. And again, you can see here things like bone fractures are common with this. Things like edema, things like gynecological symptoms can be a little bit less common with this one, but can still certainly see things like dyspareunia and vaginal dryness, all those sorts of things. If you can get away with using a irreversible one, that generally is going to be a little bit better. Just some examples of anti-androgen drugs that we could use for like prostate or testicular cancer, including flutamide, nilutamide, and the bicalutamide. These basically do the same thing as the anti-estrogen drugs, just binding to the testosterone response elements in those particular tissues. So again, by blocking that, you block that growth, that stimulant to grow that tissue there. And again, by blocking androgen activity, you're going to see more so on the estrogen side of things. So you can see things like gynecomastia, GI distress related to that. And then other ways we could drop levels of your sex hormones like testosterone and estrogen include by giving a GnRH agonist. So something like leuprolide or goserelin can basically act on the pituitary to activate the negative feedback loop and basically say, hey, we don't need any more LH and FSH being produced. So by giving a lot of that, you can shut down production of LH and FSH, and then that will then inhibit the production of testosterone and estrogen. In some cases here, you may see it used more for testosterone responsive tumors. But again, by dropping all this, you're going to see a lot of side effects. So again, you got to take the good with the bad here. So things like hot flashes, gynecomastia, impotence, all kinds of issues here by dropping levels of your hormones as significantly. All right, the next group I'll talk about briefly are going to be the biologic response modifiers. So one of the big issues with our traditional chemotherapy drugs is that they're very non-discriminate. They don't care if it's affecting a healthy cell or a cancerous cell. So the goal has always been to try to find something more specific. And so this is where we get into our biologic response modifiers. I'm not going to go over all of these because I could do a whole class just on these drugs here. But suffice it to say, I'll give you a brief introduction and a few of the more high-profile examples here. But basically, we can see that with certain types of cancers, they're going to have some very specific growth pathways that they express that normal healthy cells don't normally. So we're just trying to find ways to be more specific. So for instance, if we can affect the protein kinase pathways, that can be really specific because we see that we have things like specific insulin receptors or epidermal growth factor receptors. And so we have all kinds of very specific tyrosine kinase receptors we have here that only cancerous cells may express. And by targeting those specifically, we can save all their healthy cells. And you're going to see that the side effect profile is much better for these drugs, even though they still remain pretty effective for the cancer itself. To give you an idea, here's the tyrosine kinase receptor here for the cell. And you can see how varied and really profound these receptors can be in terms of causing cell growth and reproduction and maturation, all these things here. So by interrupting this, you can have a pretty powerful way of preventing these cancer cells from growing. So that's our goal. But we're going to see that these are also very use case specific. So it's not going to be that every patient is able to benefit from this, as we'll see here in just a moment. So here are two examples. Here's imatinib and then gefitinib. Imatinib is a drug that works specifically on this myeloid tyrosine kinase receptor. It blocks it and is only able to work on very specific types of cancer. So if you have CML, chronic myelogenous leukemia, and you have this very specific mutation called this BCR-ABL mutation, then you will respond to this drug. If you don't have that mutation, you will not respond to the drug. So it works really well for them, and it's really specific for those particular cancer cells, but it doesn't work for a large population. So again, that's why we need to do sometimes genetic testing to see if they're going to be responsive to this. And if they can get the drug, it's awesome. It's great for them because if you look at the side effect profile, it's really not nearly severe as we saw with the other traditional chemotherapy drugs. But again, it's more specific, but it's also going to be much more selective in who can benefit from it. Here's an example of an epidermal growth factor inhibitor, gefitinib, which works on usually like non-small cell lung cancer, and again, much more specific, limited in terms of side effects. You may see some nausea, vomiting, but you don't see the same dose limiting myelosuppression. You don't see the same neuropathies. You don't see nearly as much nausea, vomiting as some of the other agents here. So that's kind of the benefits for using things that are quite specific. We can also utilize antibodies. So we can engineer antibodies to target some of these specific growth factors. So we'll go over a few of these. And again, I've alluded to MABs before. We've seen them being used for things like rheumatologic conditions, but things like rituximab, alemtuzumab, they're all going to have very specific targets that they're shooting for because they're antibodies, so they're looking for something quite specific there. Again, I don't really care if you know if it's chimeric or humanized. This does have some implications in terms of the how likely your patient is to have infusion reactions or have like an allergic reaction to the drug here. If it's more human protein than anything else, then your body is much more likely to accept that, versus if it has a lot of like mouse protein in it, then it is more likely to have an allergic reaction to that, which can be seen as like infusion reactions where you get like, fever and myalgias and whatnot, all the way up to full-on anaphylaxis. Again, I'm not going to go over every single one of these because, again, that would take me a whole semester to do. So I'm just going to focus on a few more high-profile examples. But if you see some of the ins in MAB, look it up. Look up to see what his target is because it may be very specific for a certain disease state. Here's an example of one that we can use for certain types of leukemias because rituximab actually binds to the CD20 antigen on B lymphocytes. And so if you have non-Hodgkin's lymphoma, you can see here that about 90% of those patients will express that CD20 antigen. So that's like a really good target there. You could use rituximab to bind up all those cells and basically lead them to destruction through the complement system. Again, very specific in that. And then also is something that's important for regulating cell cycle activation. So if you block that as well, then those cells don't get the signal to actually reproduce there. So very nice in terms of its specificity for those particular cells. And again, helping to avoid that sort of shotgun approach that we take with things like alkylating agents. You're going to see a lot of infusion-related reactions to this because it is chimeric, has mouse protein in it. So if your patients all of a sudden have a hankering for cheese, just kind of indulge them if you can. Kidding. But you're going to see a lot of infusion-related reactions. So frequently we need to pre-medicate these patients with corticosteroids and Tylenol in order to prevent them from having this kind of flu-like syndromes here. And then certainly if they have full-on anaphylaxis, and we bust out that epinephrine and antihistamines and things like that. But again, you can see very mild myelosuppression, but nothing like you would see with a lot of other sort of non-specific cancer drugs. So again, there's a lot of different antibodies that are out there. I just want to illustrate just how we can use those very briefly here to avoid you kind of getting kind of info overload from that standpoint. Now I just want to talk a little bit about actual administration of chemo drugs here briefly. Again, many regimens are going to be count dependent, meaning you have to give the body time to recover from the last dose of chemo that they got there. This is where we're going to be using our platelets and our absolute neutrophil count to monitor. And again, you can take your white count, and if you have the percentage of neutrophils being expressed, you can just multiply that percentage by the total white count and get your absolute neutrophil count. Again, that tells us how severely immunocompromised the patient might be. And then you'll monitor organ function, and this is going to be more specific based on the drugs that you're using. So for instance, with like methotrexate, I'm definitely monitoring liver function and renal function for that, versus something like cisplatin, I'm more worried about the renal function than I am anything else, right? And then how these drugs are going to be dosed are typically, you can see sometimes based off of age. So depending on the age of the patient, they may be getting certain types of dosing. Oftentimes we're going to use body surface area. So instead of just saying you're going to get this many milligrams per kilogram, we're going to get this many milligrams per meter squared of the patient. And so that's a very specific calculation using both the height and the weight of the patient. And we get their body surface area. And it's a very specific way to dose that stuff. And then occasionally might be weight-based as well. But most of the time we're using BSA for a lot of those drug dosing for those patients there. Now, again, these drugs may not just be toxic to the patient's cancer cells, but they can be also toxic to the providers, the healthcare providers' cells as well. And so it's really important to make sure we're using PPE when handling these drugs. Typically, most hospitals will have whole policies dedicated to how to handle hazardous medications, and these certainly fall into that category. So things like gloves, gowns, shoe covers can be really important, especially if there's any chance the patient may be aerosolizing some of these drugs here. I'll give you just one example briefly. We actually had a patient who was getting a 5-day continuous infusion of, I think it was methotrexate at the time, and it was like a teenager. And like to be stuck in the hospital for 5 days, having this bag infusing into you, that's the only reason why you're there. You probably get pretty bored. So you want to walk around and kind of do whatever. And this is at a time where the hospital was new and, we didn't have strict policies on things. And so the patient was kind of wandering around the hospital, on different floors, kind of checking things out. And then one of our technicians was actually walking by, and the patient must have got hooked up on something because all of a sudden his IV line gets yanked out, and now he's starting to infuse this this chemo drug kind of everywhere. And like what you're supposed to do in those cases there is like call environmental services, and they can come and kind of set up a means of trying to make sure that chemo is not going to be exposed to other people in the area. Unfortunately, that was not done. The guy that got exposed was not aware of the process and all of that, and so they end up having to do things like make sure cancer patients aren't able to leave the floor if they're still receiving chemotherapy and stuff like that. But again, it's just one of those things where we had an inadvertent exposure to an employee that could potentially lead to things like carcinogenesis and things like that. Probably a low risk, but it could still be an issue. But not only is it just like the drugs that are being infused into the patient, but also looking at things like their excretion. So like if they're a young child, so maybe on diapers or pull-ups, like that diaper may be considered hazardous because their urine contains some of that drug in there. So blood as well. So those are things you always want to make sure you're protecting yourself, using good PPE, and make sure that you don't cause yourself any undue harm as a result of using this stuff. Now, as I mentioned, in terms of the total number of drugs the patients are getting, a lot of them may not be the actual chemo drugs. A lot of them are going to be meds used for supportive care. And so, for example, in some cases, in order to help patients recover their blood cells after receiving chemotherapy, we can sometimes give growth stimulating factors here. And so basically we can give hormones that are going to help to kind of stimulate growth of things like platelets and your white cells in order to help out with this. Sometimes we'll even give erythropoietin stimulating agents like we talked about in the nephrology section to help, again, get their red blood cell count back up. Again, these take time. And so this is why we can give these to try to speed that process up a little bit there. Other things to consider when you have patients that are, myelosuppressed is you want to be really careful for a couple of things. Like, for instance, don't give them fresh flowers or fruits that don't need to be peeled because that can lead to having bacterial exposure that they cannot fight because they don't have a competent immune system. Or, for instance, things like rectal administration in neutropenic patients, you don't want to do that. You don't want to do anything rectally in patients who are neutropenic because of the fact that, one, the GI cells are heavily affected by chemotherapy, so that tissue in the rectum may be more friable or more brittle. It can break. And then if you cause any transposition of rectal bacteria systemically, that can lead to profound and even fatal infections there. So little things to kind of think about when you have patients who are receiving this chemotherapy and sort of what are the side effects or the complications thereof. Again, these patients may recover on their own, but sometimes we'll give these colony stimulating factors. Sometimes we'll give granulocyte colony stimulating factor in order to help reproduce red blood cells, granulocytes, all those sorts of things there. From a GI standpoint, again, very common to see nausea, vomiting. Not every drug is going to be equal in terms of this, but like we've already talked about the GI drugs already, but just remember all those kind of cancer or antiemetic drugs we use there, including your phenothiazines like metoclopramide, all of your serotonin antagonists like Zofran and aprepitant, was a substance P antagonist. All those there are going to be utilized here in order to help manage the nausea, vomiting these patients are going to get. And even in some cases, patients get anticipatory nausea, vomiting, where they remember how bad that they vomited last time they got the chemo. So that way, when they are about to get the next dose, they already start to vomit just in anticipation of that. Kind of like if you had bad seafood one time, and then the next time you see that same seafood again, you get nauseous. That's the same thing happening there. That's where things like benzodiazepines, like Ativan, can be very useful. Now, because you're affecting their GI cells and preventing them from replicating as easily, you do see things like stomatitis and mucositis that can happen for these patients. And that can be very painful. It may lead them to not get enough fluid in, to not get enough food in. And so that can also lead to oral infections as well. So it's really good to have good oral hygiene help prevent that. So things like saline rinses or even an antiseptic like chlorhexidine can be useful here to clean the mouth up and make sure they don't get any kind of secondary infections from that standpoint. Here's just an example list of the emetogenic potential of some of our cancer drugs. Now, don't memorize this by any means, but you can see here that, the high risk ones are more than 90% likely to vomit. Like I wouldn't want to take anything that's more than 90% likely to cause me to throw up because it's pretty miserable. But you can see things like cisplatin here. Some of this is going to be related to the dose that you're getting, but mostly you see here the a lot of alkylating agents tend to be pretty rough from this standpoint here. So again, just to give you an idea of sort of the additional drugs we have to give, not just for the cancer, but for all the side effects from the medications that we're using to treat that cancer. In terms of alopecia, this is pretty distressing to the patient. I know I'd be upset if my hair all of a sudden fell out all at once. There's not really anything we can do for this besides give it time to recover after they've done with the chemotherapy. It's really kind of wild too because sometimes the hair will grow back with like a different texture. So someone who had straight hair before may come out kind of curly, which is kind of interesting from that standpoint. And then, as I mentioned, the extravasation can be pretty severe, especially with the taxanes, the vinca alkaloids, the anthracyclines. This can lead to very severe tissue damage. And so this is very dependent on the drug in terms of if they need heat or if they need cold compresses. But again, just look it up if it happens while you're dealing with these patients here. And interestingly enough, we can actually give a drug called hyaluronidase sub-Q. It actually helps to break down some of the subdermal connective tissue and actually helps the drug to be absorbed more quickly. So sometimes we can use that to help aid the systemic absorption of the medications faster there. So that's it for the chemo drugs, our chemo section here. You guys have any questions? If not, I'm going to move on and do our surgical section. You can get caught back up. Questions? Oh, you guys are my quietest group. Probably because it's 8 o'clock in the morning and you guys are all tired. Barely conscious if I had to guess. That's okay. I'm barely conscious too, if you can't tell. All right. So continuing on, let's talk about surgery. Talk about some of our general anesthetics. These are going to be drugs used to help keep our patients asleep while they're under the knife here. And again, you may not be the ones to give these general anesthetic drugs. As PAs, I don't see that happening a lot. Mainly, you're going to see a lot of your anesthesiology cohort helping out with this, like in terms of CRNAs, anesthesiologists, things like that. However, plenty of PAs that I work with work in surgery, and so you may be there in the actual surgical suite, and so you see these drugs being used. So it's important to know what they're doing, why they're doing what they're doing, side effects that you can see, all that sorts of things here. So when we're talking about general anesthetics, we're going to be talking about utilizing something called balanced anesthesia, which is basically a mixture of both inhaled and IV medications in order to get the patient asleep as quickly as possible, keep them asleep for the duration of the procedure, and then allow them to recover as quickly as possible afterwards. So that way they can go back, they can leave the surgery center, or they can go to the floor if they're in the hospital, wherever they're going to go. That way they can recover that much faster. You hear me talk about the PACU. If you're not familiar with what a PACU is, it's a post-anesthesia care unit. That's usually where people go after they've received these anesthetics during surgery to recover, because we'll see there's going to be some side effects associated with this, and you make sure the patient can breathe on their own, they're kind of awake and with it enough to protect their airway and whatnot. Another thing I'm going to talk about here briefly as well, it includes a minimum alveolar anesthetic concentration, or the MAC. This is basically just a general term used to talk about the dose needed for a drug in order to get 50% of patients to not respond to painful stimuli. Now, we obviously are not going to dose at the MAC because you don't want 50% of your patients to not respond to pain, because that other 50% is going to be pretty mad when you try to cut them open. But it's useful to help to compare different anesthetics to one another. Right. And so again, because these are inhaled anesthetics, we're going to be talking about the percentage or the concentration you have to get in the inspired air in order to cause this. Obviously, analgesia is something we've talked about extensively, but this is a decreased awareness of pain. Sometimes you'll see some amnesia associated with this. And then general anesthesia is, again, that state of unconsciousness, amnesia, analgesia, all of this. And also you're going to find skeletal muscle relaxation.
is really important too, because if you have a patient who you're trying to, say, cut open for an abdominal surgery, you don't want those muscles to be tight. They need to be nice and loose. That way, they provide minimal resistance and issues there. Obviously, anesthesia is that physiologic state that's going to be induced here, and we'll see that there's actually different sort of levels of anesthesia that we can develop based on how deep of a sedation we're causing. Sometimes you don't need a very deep sedation, right? So if you're doing like a more minor procedure in the ER, like you're doing a pretty big IND, or if you're trying to reduce a fracture, you may need a different level of sedation than if you're doing open heart surgery, right? So again, we're going to talk about sort of the spectrum here a little bit in terms of anesthesia, and when we might use one drug versus another here. So when we're talking about amnesia, this is again sort of this abolition of sensation. Oftentimes that can include awareness of pain, and ultimately you're going to find the patient will be unaware of kind of the situation going on around them to some degree. Amnesia can either be anterograde or retrograde. Anterograde basically means memory stops being formed once they receive the medications, everything from that point forward. So you can kind of think about like alcohol is pretty common for causing anterograde amnesia. Retrograde means it would then go backwards in time. They would forget details going up to that. So frequently you're going to find a lot of our medications that we use will cause a little bit of a mix of the two. So if I have someone who fell off of a horse and broke their arm, they'll probably remember the fall, but they may not remember all the details and them going to the hospital, them getting their bones set and all that kind of stuff. So but we're going to see here this also helps out with skeletal muscle relaxation. Imagine if you had a femur fracture and you're trying to set that femur back, but the patient is all tensed up due to the pain. You're not going to be able to set that, right? So you need to have the patient be very relaxed, and this is what our medications can help out with here, right? And again, patients in terms of level of sedation, it can vary greatly. We oftentimes will talk about the level of sedation in terms of what is the patient responding to. Do they respond to voice? Do they respond to a sternal rub where you take your knuckles and rub it along their sternum? If you don't believe that doesn't hurt, try doing it to someone else, and they will tell you to stop doing that. And you can say, "Wow, you're not very sedate, are you?" But you'll have patients who you can do sternal rubs to, and they have no response to it based off of whatever substances they have there. Now, again, when we're talking about amnesia versus analgesia, these two are not synonymous, and not every drug we're going to talk about will cause both of these. And so it's important that sometimes we need to mix drugs in order to make sure that we get both good amnesia so the patient's not really aware of what's going on, and also the analgesia so the patient's not responding to that pain. Okay, so we'll kind of talk about that delineation here a little bit as we go forward. So with balanced anesthesia, we're going to find that we're going to utilize both inhaled and IV medications in order to put the patient under quickly and then keep them under for the duration of the procedure and then allow them to then recover afterwards. So typically we'd like to have an ideal anesthetic that would be, provide a nice smooth, rapid loss of consciousness. So within a couple of seconds to minutes, they should be out. And then allow them to, once you stop the medication, they wake right back up. And then hopefully we'd have a wide margin of safety to where even if we gave, more dose than we needed, the patient wouldn't have any adverse effects. But we're going to find that's not really going to be possible here. So we're going to utilize multiple meds, and that will allow us to kind of get the best of both worlds. But we'll see some of the downsides of our different medications here. So the choice of anesthetics we're going to use can vary. As I mentioned, it can depend on the type of procedure you're doing in terms of how minor or major it is. If you're doing more of like a minor procedure, you may just, something like, suturing, or if you're doing like maybe if you work like an aesthetics clinic and you're doing some kind of, dermatologic procedure, something like that, you may only need oral or parenteral sedatives, right? You may only need like oral diazepam, for example, an oral benzo, and maybe some oral opioids, like a Percocet or something. Or you can utilize local anesthetics, which we'll talk about later, like lidocaine and things like that. That may be sufficient. The patient is probably still going to be fully awake. Let me gloss over a few of the details there because they're kind of drugged up, but other than that, they'll be awake and breathing the whole procedure. For major procedures where the patient needs to be fully unconscious, this is where we're going to utilize things like preoperative benzos like Versed. We're going to use intravenous anesthetics to put the patient under. We'll talk about some of those drugs here coming up. And then we'll use a combo of inhaled and intravenous anesthetics to keep them asleep for the duration of the procedure. And again, typically they're not going to be breathing on their own, so you typically have to intubate the patient here. And then once they're done with the procedure, they can then stop the drugs, extubate the patient, and then they can recover. Hopefully it'll be a fast recovery. So we'll talk about mainly the inhalational drugs, and then we'll also talk about the intravenous drugs here as we go forward and talk about sort of their utility and downsides in both cases. In terms of the inhaled anesthetics, we have these are going to be things that are going to be vaporized and put through usually the ventilator circuit. So when you intubate these patients, they'll be getting oxygen through that, but they'll also get to some degree these inhaled anesthetics. This can include things like isoflurane, desflurane, and sevoflurane. And then for more minor cases, you may also see some nitrous oxide used here as well. So we'll talk about the laughing gas here in just a little bit. In terms of IV anesthetics, we'll talk about our barbiturates, benzos, propofol, ketamine, and then some opioids, and then a couple of miscellaneous sedatives here. And again, we can use these either by themselves or in combination. And I'll talk about some cases why you might want to use some combos of one drug versus another here. And as I mentioned, the inhaled anesthesia is good for keeping patients asleep throughout the procedure, but they take too long to knock them out. Versus the intravenous drugs are going to be better for a really quick induction of anesthesia, right? So if I give someone a big dose of propofol, they're going to be out within a couple of minutes. Versus an inhaled anesthetic might take kind of too long for that stuff to kind of kick in. Other really big beneficial things we can do, and again, generally speaking, like when you're recovering from surgery, the fewer the opioids you can give, the better. Generally speaking, if we can use less opioids, or the patient's gonna be better off from a whole host of different reasons, like post-op constipation and ileus. They recover faster, they can get out of the hospital faster, and so to that end, we can use a lot of things like local and spinal blocks. So we can actually utilize local anesthetics to cause regional anesthesia, so that way the patient doesn't feel pain from a certain area, and that will help to limit how many opioids they're going to need to take systemically. So for instance, if I have a knee replacement done, well, the pain's only coming from that knee, so if I can deaden all the sensation from that knee, then the patient's not going to be feeling a whole lot of pain, right? So we'll look at some ways we can do that as well with our local anesthetics later on. So as I mentioned with the inhaled gases here, we're going to see that how well it's going to work is going to be dependent on what kind of concentration that we're giving. And we'll obviously see some of these are more potent than others. So for instance, like nitrous oxide is not a particularly potent anesthetic. It would be, in order to get a patient ready for like open heart surgery, you'd have to give so much nitrous oxide the patient's not getting any oxygen and they would die from that, right? Some drugs are just never going to be that potent, but they can still have their uses. Like nitrous for like minor procedures is great, right? You don't need the patient to be fully unconscious. But basically, we're going to see that these drugs need to have a pretty good lipid solubility, so that way when you inhale them into the lungs, they can partition into the blood, and then once they're in the blood, they can then partition across the blood-brain barrier and then get into the CNS to have their effect. So how fast that occurs may affect how, or may be dependent on how lipophilic the drug is, right? How easy it is able to partition, and so that can have an effect on how quickly it comes on and how quickly it comes off, right? So how these drugs are working typically is going to be through GABA-A. By activating GABA-A receptors, you're going to see you're going to have more chloride flowing into the neurons. That's going to inhibit them. And so overall, you're going to see a global CNS depression here. We're going to see that this is, again, utilized with a lot of the IV drugs that also work through GABA-A as well. And again, these drugs can be very synergistic by kind of working at different sites on those GABA neurons. But overall, hyperpolarizing those neurons in the CNS cause global depression. So, as I mentioned, you'll typically see these used with IV drugs, but the four main ones you're going to run into include nitrous oxide, isoflurane, sevoflurane, and then desflurane. So, as I mentioned with the MAC, that basically means like what concentration would you need to get 50% of your patients to not respond to noxious stimuli? Some people have called me a noxious stimuli in the past, but typically for most patients, in order to get them asleep, we would use about 1.3 times the MAC, and that's pretty good to get most patients down. But you can use different MACs to compare different drugs together, or use their MACs to compare them. But you also see certain disease states may lead to a higher or lower MAC. So for instance, like sex, height, and weight doesn't really matter, right? So you can use the same concentration of an inhaled anesthetic for a male patient versus a female patient, or someone who is 300 pounds versus 100 pounds. Like it really doesn't have a huge effect there. But certain things can affect the MAC. So, for instance, people who have a decreased MAC, meaning they are more sensitive to the effects of the anesthetics, can include things like hypothermia. Being elderly, you respond better to those drugs at lower concentrations. People have increased MAC who may require a higher concentration in order to get the same sedative effect. They include things like alcohol abuse, pregnancy, or if they have chronic use of things like benzos or barbiturates, because they're already used to having a lot more of the GABA activity around. So it would take an even stronger stimulus in order to inhibit that further, right? So that can be sometimes a challenge where you're thinking, well, wow, this patient's not really going down. What's going on here? And it has to do with the fact that they're sort of used to having a lot of centrally acting depressants on board anyway, like with alcohol abuse, for instance. So, what are some of the effects we can see on the body outside of just the anesthesia we're going to get here? Certainly, we can see respiratory depression. So, oftentimes these patients will not be breathing on their own if they're getting these inhaled anesthetics like sevoflurane and things like that, which is probably okay because having surgery done. And so, oftentimes they're going to be intubated. Okay. Not all drugs are going to be the same at causing this. So, like nitrous oxide, very unlikely to cause significant respiratory depression unless you're combining with like a ton of other meds. You're going to see decreased blood flow through the renal and hepatic systems. You're going to see decreased metabolic rate. Overall, everything's kind of slowing down for the most part. So, getting to the specific inhaled anesthetics here, we're going to see that they can vary a little bit in terms of like their onset or their the recovery phase. So again, we want something with a fast onset and fast offset. And isoflurane is the first one here we use pretty commonly. This is nice because it has a good muscle relaxant ability. So again, you want them to have very loose muscles, so that way when you're trying to cut into their belly or their chest or something like that, again, it's going to be more compliant. You can do your surgery better or more easily there. We used to use things like halothane and enflurane, but those drugs didn't really have very good pharmacokinetic profiles, and so isoflurane has largely replaced those because it does provide more rapid induction. Patients go down faster, and they also have faster awakening, right? So it gets into the system faster and out faster as well, which is good. That way the patient can recover more quickly. We don't see nearly as many post-anesthetic organ toxicity. Seizures are less common here, and it doesn't really induce arrhythmias that often. So from that standpoint, that's why it's kind of preferred over some of these older agents that we used to use, right? You will see things like hypotension related to this, respiratory depression, and increased cardiac output. But again, you can see some kind of variable cardiovascular effects here. And I'll have a table a little bit later to kind of demonstrate that, I believe. Next, we'll see desflurane or suprane is used in sometimes like emergency surgical settings, outpatient surgery sort of settings here. Again, not very good from an induction standpoint because it has a very kind of slow onset. So you might use something IV to get the patient knocked out first. But this is nice because it has a really rapid recovery. So if you're going to be sending your patient home afterwards, this might be a really good drug to use because they can recover so quickly. Here you're going to see things like myocardial depression, respiratory depression, and you can also develop laryngospasm, which is rare, but can be life-threatening. And so we at least have in our surgical area something called a laryngospasm kit that can occur where if your larynx all of a sudden starts to spasm up, you're not going to be able to breathe very well. And so it includes some sedatives and a paralytic in order to allow that to relax, and then we can breathe the patient during that period there until the laryngospasm sort of recovers on its own. Next, we have sevoflurane. This has, again, quick onset, quick recovery here. A lot of these drugs you're going to see post-operative nausea, vomiting, so it's not uncommon for patients to get doses of Zofran either before, during, or after surgery in order to help prevent this. Here you can see bradycardia associated with this more commonly, hypotension, and sometimes you'll see some tachyarrhythmias, but most often you'll see some drops in the heart rate here. And again, typically during surgery, you're going to have someone who has their eyes glued on the monitor to see what their blood pressure, heart rate's doing. It's usually the anesthesia personnel there that are helping out with that. Then we have nitrous oxide or N2O. Note this is not nitric oxide. It's a very different drug used for different indications here, but this is laughing gas. And so basically this is used a lot for like outpatient dental procedures. It is, minor, procedures like, I see this a lot of times like in aesthetic settings. So if it's something you don't need the patient to be fully out because you don't want to support them from a respiratory standpoint, things like that, this might be useful. And so oftentimes it's not going to be sufficient on its own, but you'll use it in combination with other things like benzodiazepines or opioids or things like that. However, it's also, not going to be severe in terms of respiratory and cardiovascular standpoint, so patients can recover pretty quickly from it. Good. We'll see some hypotension associated with this, which is usually pretty minor. And interestingly enough, this can actually cause gas and air cavities in the body to actually expand. And so there's certain cases where you actually don't want to use this because you can actually cause rupture of membranes. So for instance, if you have someone who got into a car accident and came in with a pneumothorax and you need to place a chest tube, frequently we'll go ahead and do a sedative along with that. But if you gave them nitrous oxide, that can cause that pneumothorax to worsen. Or if you had, say, bowel distension, this can cause that to worsen. So that'd be one thing that you want to be cautious with whenever utilizing nitrous oxide. And this also has a high incidence of post-op nausea, vomiting, so giving something like Zofran is definitely going to be necessary here. Because again, patients who have just been under anesthesia, they may not be able to protect their airway very well. So if they are vomiting and they aspirate that, that can lead to a lot of bad problems in terms of causing a chemical pneumonitis. So we like to pre-treat, give them something to prevent that nausea vomiting in the first place, and that will help. You will find that nitrous oxide itself can actually lead to some anemias if used chronically. And again, this wouldn't be for most patients, but you will see nitrous oxide is a pretty common drug used by people who are abusing the drug. So particularly healthcare providers have easy access to the nitrous oxide. This is a fairly common one to see people abuse. But you can actually see anemias related to some of its effects on some B vitamins. And we also don't want to use this in pregnant patients and immunocompromised patients, since this can cause some issues in terms of their blood cells being affected, and especially in the fetus there. So you want to be avoiding that. So one thing we can see that's a rare but really serious side effect from use of the inhaled anesthetics, not nitrous oxide so much, but certainly the other ones, something called malignant hyperthermia. And this is something that is a genetic condition. It's an autosomal dominant genetic condition. It's pretty rare, but still, if a patient has it, they can lead to some huge issues here. And basically, this is why you always want to do like a really good history with patients to see if they've ever had someone in their family have a bad reaction to surgery. If they have, then you can do some further investigation and check to see if the patient has this genetic mutation here. But basically, it's an alteration in this ryanodine receptor. So why is that important? Well, basically, normally when you're looking at the skeletal muscle here, normally what happens is you have calcium come in through the cell, and this causes calcium to be released from the sarcoplasmic reticulum that then causes the myofilaments to come together, and that causes the muscle to contract, right? Well, what happens if someone who has this ryanodine receptor here under the presence of the inhaled anesthetics, you get way too much calcium being flooded out of the sarcoplasmic reticulum. This is going to cause the myofilaments to contract way too much. So the patient gets very tense, muscles get very tight. They're going to burn through oxygen and glycogen and glucose very quickly. And so they're going to switch over to needing to anaerobic metabolism, and they're going to start to produce lactate. So they get very hot, and the muscles being all bound up. They're going to get acidotic, and they're going to get very rigid. Obviously, this is not good in the middle of surgery. And so it's something that we have things like malignant hyperthermia carts available, because we do know that once we see this and recognize it, it needs to be treated pretty promptly. So again, you can see this rapid onset of tachycardia, hypertension, severe muscle rigidity, hyperthermia, hyperkalemia, and acidosis here. So not great. So what do we do for that? Well, basically, we want to reduce their temperature, so we can do things like cooled IV fluids. We want to do things like correct the acidosis, so we can do things like giving them sodium bicarb to try to alkalize the blood. And then the true treatment, the actual antidotal drug here, is called dantrolene, which actually is going to be a peripheral muscle relaxant and will reduce that calcium release from the sarcoplasmic reticulum. So that's the thing that's actually the curative agent here. In addition, you're also going to be reducing their temperature. Again, they're treating hyperkalemia, fixing the acid-base balance, and all of that. So if this is going to happen, it's going to be mostly with the inhaled anesthetics like sevoflurane, isoflurane, things like that. And then also there's a paralytic called succinylcholine we might be able to talk about a little bit later on, but that can also lead to this as well. So key points here is that then inhaled anesthetics are going to lead to this kind of beneficial amnestic effects. We like the ones that we use because they have quick offset, which means faster recovery, which means you can get them out to wherever they're going to go eventually and get more patients in, which also is useful. and is going to be providing additive effects to the IV anesthetics, which we're going to get into next here. In terms of monitoring, the best thing is going to be to monitor for that nausea, vomiting. So again, a lot of patients are going to get Zofran following surgery or maybe even during surgery. And again, watch out for that malignant hyperthermia. So, in terms of intravenous anesthetics, you may see this can either be utilized as an induction for general anesthesia, like we talked about before. In some cases, you're going to use these as monotherapy. So, for instance, I have some patients are coming in for something like, a displaced fracture that needs to be reduced. This is really the realm for IV anesthetics because it's a quick procedure, but you need the patient to be, it's going to be painful when you do it, but you need the patient to be pretty compliant. And so this is where IV anesthetics can be very useful here. Most of them you're going to see lack analgesic properties, so you need to use something in addition to help cover that, usually some sort of opioid. And again, most are going to be pretty quick in terms of recovery time, but a lot of this is dose dependent. It really depends on how long the procedure needs to go for. So we'll talk about a few of our drugs here, including our barbiturates, benzos, opioids, propofol, etomidate, and then ketamine. These are the main ones you're going to see being used for surgical purposes. First off, for the barbiturates, we have a few here, including thiopental, phenobarb, and pentobarb. These are the ones I don't see used quite as frequently nowadays. I mean, certainly phenobarb we use all the time for neonatal seizures, but in terms of being used for procedural sedation, I don't really see a ton of it, mainly due to a lot of the other drugs we have nowadays having kind of more favorable pharmacokinetic and dynamic sort of profiles here. But this is still the drug of choice for patients that are getting electroconvulsive therapy, and it's shocking to hear that, but you can utilize barbiturates to help sort of sedate the patient when you're shocking them for their depression or whatever the case may be. These are also good for induction agents prior to getting other inhaled anesthetics, but lacks any sort of analgesic properties. So the patient's in pain, they'll still be in pain, may not remember it, but they will certainly still be responding to that pain potentially. You'll see decreases in blood pressure, cardiac output, which is pretty typical here. And then you can see some drops in intracranial pressure, which may be good if you have a patient who, for instance, got into a car wreck, hit their head on the steering wheel, now they're having cerebral swelling, right? Reducing that ICP can be very beneficial, can prevent them from herniating, and so barbiturates have a nice place with that. Benzos are used a lot as adjunctive agents, usually to help out with things like anxiolysis. A lot of patients going to surgery are very anxious, or if they just had an injury, they're pretty anxious about it. This also helps to provide some of that anterograde amnesia. So from the time they get the dose forward, they'll have that sort of amnestic sort of properties there. It can also kind of prevent some acute agitation. So patients may be just a little bit more compliant with you. And so definitely for pre-medication, this is like the drug class to go with. Usually midazolam, diazepam, lorazepam, any of those drugs are fine. I see Versed or midazolam used most frequently for surgical or for surgery uses, mainly because that's the fastest onset because it's pretty lipophilic. But you're going to find that its onset's going to be a little bit slower than you'd see for other CNS depressants like a barbiturate or etomidate or something like that. And rarely is ever used as monotherapy. And again, no analgesia seen with the benzos there. So if you do something painful to the patient, they're still going to feel it and they'll still respond to it. So if you are cutting open an abscess or something like that, they're still going to, they'll let you know about it. As I mentioned, Versed we use all the time as a nice parenteral administration. We'll do this a lot for patients coming into the ER that are very needle phobic, especially little kids. We can use intranasal Versed, and that works out very well to help kind of chill them out a little bit, calm down, so we can get the IV placed finally. So you have kind of different options that are there. As I mentioned, we see midazolam is useful because of its high incidence of amnesia, good rapid onset, and then typically has a little bit of a shorter half-life. So that way it has, when you're done with it, it can be eliminated, and then you recover that much faster. If you had someone who got, say, too much of a benzo, or you needed them to sort of wake up more quickly, you could utilize the antidote here. And so just like when we talked about with opioids, naloxone is a reversal agent for opioids. Flumazenil or Romazicon is going to be the reversal agent for benzos. And so basically it will help to antagonize that benzo receptor and allows for more quick recovery. Again, I use it more so like from a toxicology standpoint if I have like an overdose. But here in surgery, you're going to see that it can be utilized to help the patient recover that much faster. it doesn't last super long, so sometimes you may need repeated doses, but this is the reversal agent you'd use specifically for benzos. Now, the opioid analgesics are going to be very useful here because they help out with some of that awareness during anesthesia. We're going to see that they are going to be useful in adjunct with things like benzos, with things like other inhaled anesthetics and whatnot. So, however, we do see that there's a lot more post-op morbidity associated with, especially if you're using a lot of opioids here. So, especially in the post-operative setting, if we can limit how many opioids a patient requires, that's going to be really good for them overall. So anything that's opioid sparing generally is going to be beneficial for these patients here. Something you can run into as well during utilization of these opioids. If you give really big doses of fentanyl too quickly, you can actually lead to chest wall rigidity, which can keep you from ventilating your patient very well, which is not great. So sometimes you either have to give Narcan to reverse that, or give them a paralytic to help relax that muscles there, or those muscles there. But again, the patients, the more opioids they're on, you're typically going to find the prolonged need for ventilatory support. The post-op ileus is more likely because you're going to have constipation associated with the opioids. So, bladder complications like urinary retention. So again, less opioids generally is going to be good here. However, sometimes we can use really low doses of opioids and give it via the epidural route, and that provides more localized anesthesia. So, for instance, like if you have an epidural placed for labor, for giving birth, that provides analgesia just where you need it, where you're having pain, instead of the whole body over. So that can be one way we can try to limit how many opioids the patient needs by giving smaller doses in the actual spinal column. So the main ones you'll see used for surgical purposes include the fentanyl family. So fentanyl, sufentanil, remifentanil, and alfentanil. Every surgical anesthesiology provider is going to have their preferred for different situations. So for instance, like our cardiac people, they love to use sufentanil during surgery versus other people that use remifentanil. They're all roughly the same. There's probably a little bit of difference in terms of their flavor, in terms of onset and recovery and things like that, but they're all pretty much commonly used for the same purposes in terms of surgery here, and are used in conjunction with things like inhaled anesthetics or other IV agents to provide good analgesia. Other things you can use too include morphine, but the benefit of using the fentanyl and fentanyl derivatives is that they're very short acting. So you can give continuous infusions, and when you don't need it anymore, you cut it off. The patient will recover pretty quickly. We utilize a lot of like fentanyl for like patients coming in for like fractures or something like that, and if they don't have an IV place, you can use intranasal fentanyl. That can provide some good analgesia in the meantime before you get your IV place or something. So it can be pretty helpful there. Remember, naloxone is going to be the reversal agent for the opioids. So flumazenil is a reversal agent for the benzos. We don't have a lot of reversal agents, so I like to point those out where we have them. Next, we have propofol, which is going to be, if you've ever seen, I don't know if I have a picture of it or not, but it's, it looks like milk, basically. You can Google a picture of it. They call it the milk of amnesia because, again, it's pretty amnestic in terms of its properties there. But and propofol really got its claim to fame, or its, I guess, notoriety, from the death of Michael Jackson. So this was the substance that kind of led to his unfortunate demise. But the way that it works is basically kind of similar to the IV barbiturates, enabled in order to hyperpolarize those CNS neurons, cause global CNS depression. And you're going to see that this can either be used for like induction and maintenance of anesthesia. So sometimes you'll see patients who are intubated, who are being sedated just with propofol, one thing. We use this a lot for like ambulatory surgery, so or for like procedural, like short procedures. So for instance, in the ER setting, if I have an adult patient who dislocated their shoulder, you could give this to them to sort of cause them to not be totally out of it. They'll still be breathing and they'll still be somewhat conscious, but it allows them to totally loosen up in order to get that shoulder back in place, and they can recover pretty quickly from there. So used pretty commonly here. So again, it's working as a GABA A receptor agonist, and you can use it in the ICUs. You can use it in the surgical realm, using the ERs. You're going to see this used in a lot of different places there. Some things you want to monitor for, and this is more so with like long-term use, is going to be either they can develop hypertriglyceridemia. So the reason why it looks like milk is because it has to go into a lipid base in order to be soluble, basically. So a lot of that lipid includes triglycerides, and you can actually see hypertriglyceridemia there. Not a problem if it's like a one-time dose for surgery or something, but certainly long-term infusions. And you can also develop this severe acidosis called PRIS, which is propofol-related infusion syndrome. This is more so seen in the ICU, where all of a sudden they're on high dose, high doses for, say a week or more. You can see this acidosis that can develop there, which may prompt you to discontinue use of the drug altogether. We like propofol because it has a pretty quick recovery time for the most part. Interestingly enough, it can also cause urine to come out kind of greenish. I'm sure if anyone saw that, they probably think they have a pretty nasty infection, but it is related to propofol. And the other things you can run into include hypotension. You will see some suppression of the respiratory drive, so you may need to provide ventilatory support for the patient and some pain at the injection site. But other than that, pretty good drug. Just make sure that patients are not having issues with their blood pressure, because again, this can worsen the hypotension. So if they're intubated in the ICU, they're septic and they're hypotensive, don't give them propofol, because this is just going to worsen their blood pressure. Next, you have etomidate. This is actually really good because it has very limited cardiovascular effects. You're not really going to see hypotension associated with this. And we use etomidate all the time to intubate patients if you're doing what we call rapid sequence intubation. We do this pretty commonly here, and we like it because it has minimal cardiovascular effects and minimal respiratory depression. It causes really rapid loss of consciousness. So when you're about to intubate someone, you want to be able to knock them out quickly, be able to get the endotracheal tube in, and then hopefully you're done within a couple of minutes, and then that patient can then recover, and you'll probably put them on some other sedatives. But this is why we like etomidate in that case there. So recovery fast, probably a little bit less than 10 minutes here. It's a pretty fast onset. And it's also, you're going to see, it also loosens up all those muscles when you give it to them, so that way you can successfully intubate the patient. In terms of adverse effects here, you can see some myoclonic activity, so you can kind of see some myoclonic jerks that happen here, and occasionally you can get trismus, which can actually cause a jaw to kind of lock up, which is not good if you're trying to intubate the patient. You'll see some post-op nausea, vomiting, and then this is sort of unique to etomidate, but you can find some adrenocortical suppression. It can actually cause drops in their cortisol levels, which may have effects on things like their blood pressure and things like that. So it's something you want to watch out for, especially if you're receiving a patient who just got etomidate. Next, we have ketamine. This is a pretty interesting drug. So this is, instead of working on GABA A receptors like everything else we've been looking at so far, this is actually going to work to block the activity of glutamate, which is normally an excitatory neurotransmitter, and block at the NMDA receptor. And ketamine itself is actually chemically related to the drug called PCP, or phencyclidine. It's not really used a whole lot nowadays, but it used to be called angel dust. And so kind of does the same thing, blocks the NMDA receptor here. What's really cool about this is that instead of just like knocking the patient out to where they're unconscious, this causes what we call a dissociative anesthetic state, where basically the patient's going to be in a state where their body is sending signals in pain or something like that, but it's never reaching the brain there. So they're not really aware of kind of what's happening around them. And so you can have patients who are getting a procedure done where they may still kind of like groan somewhat. They may still say like words. They may even respond to you with just voice, but they're not aware what's happening. And so some people describe it as sort of an out-of-body experience, which is probably why it's been abused for sort of psychedelic sort of purposes here. But another big thing we like it for is it doesn't really hit the respiratory drive. So we use it all the time for procedural sedation in kids, for like fractures or INDs, like really involved INDs, things like that. Really beneficial. Oftentimes we'll have the kids and we'll say, okay, well, what's your favorite thing to do? And they're like, oh, I love to play baseball. We're like, okay, like who's your favorite baseball player? Imagine that you're playing baseball with Mickey Mantle or Babe Ruth or somebody. I don't know any current baseball players, but imagine you're playing baseball with them, and then they'll go to sleep. Basically, they may see, their eyes may still stay open. They may be kind of fluttering. You may, you do your procedure. They're not going to respond to anything. And then when they wake back up 20, 30 minutes later, say, hey, how was it? And they're like, it was great. I was playing baseball with these really old guys. I had no idea who they were, but it was awesome. And they have a great time, right? Kids do a lot better with ketamine than adults do, because adults can have what we call a dysphoric reaction, which we'll talk about here in just a moment. But again, ketamine is really nice because it provides both anesthesia and analgesia, which most of our IV anesthetics don't do. Most of them only provide one of those. But it's also, you can see that as I mentioned, you can have this as post-op psychic phenomena, which is oftentimes a sort of dysphoric reaction that can occur. And I see this more in adults, to where they can become very agitated. Instead of having a nice dream where they're playing baseball, they might, like, I don't know, be attacked by spiders or something. So adult patients may not respond to this as well. And they come out and they get pretty aggressive or agitated. You may have to give them like benzos to calm them down. So for a lot of like adult patients for those short procedures, I see more propofol being used. For kids, we use ketamine all the time. So the other beneficial thing here as well is that it actually causes some bronchodilation, and this is really helpful if we have someone who has like status asthmaticus. So we can help them to, if they're being intubated for their asthma because it's so severe, we can give them ketamine, and that helps to bronchodilate some, and that may be our sedative of choice for that, which is cool. So this is kind of a nice comparison slide here to kind of go and compare and contrast the different drugs and kind of pick out like why we might choose one versus the other, including some of the side effects there. So again, when you're thinking like on a test question, I could ask, hey, you know, patients being intubated, or they're they are undergoing a minor procedure and they have this comorbidity. What might be the best drug for them, or what drug might be contraindicated? These are the kind of things I might be looking at. So these things you can kind of go back and review to give you some clues in terms of like what kind of things I might ask about, and what kind of things may lead one drug to be more beneficial or more detrimental than another. Because I like to ask questions like that on tests. So anyway, we're doing what we call conscious sedation. This is for people who don't need to be like fully out and under like general anesthesia, like you might see for say someone going for an appendectomy or open heart surgery. But for like ER settings or urgent care settings where you're doing something where I just need the patient to not really be fighting me while I'm trying to do this procedure, I need them to be kind of loosened up to reduce that fracture, whatever the case may be. We can have the patient still maintain a patent airway. They may be responsive to verbal commands, but they're just really kind of nice and loosened up and really kind of, sedate enough, but not so sedate that I have to worry about like intubating them. Okay. So this is where drugs like diazepam and other benzos are useful here. Propofol, ketamines I've kind of alluded to, typically are used most frequently. The nice thing with the benzos and the opioids is if they do have too much or too exaggerated of a response, can have reversal agents for them. If someone gets too much propofol, there's not a whole lot you can do for that besides just wait it out and support the patient through with either blood pressure support or respiratory support. So those are kind of some of the benefits of benzos and opioids there. One other drug we might use occasionally to help sort of provide a nice light sedation is called dexmedetomidine or Precedex. And this is actually in the same category as like clonidine or guanfacine, but it is used IV, as it usually continues infusion because it has a really short half-life, but it works as an alpha-2 agonist. So by activating the alpha-2 receptor, you're going to see suppression of the sympathetic nervous system, but also overall decrease in sort of consciousness, but very light, very, very minimal. You're not going to be cutting into anyone using Precedex by itself, right? But if you need just something very light to keep the patient kind of still, chilled out, this can be useful there, especially like after surgery. Very minor analgesic effects, light sedative effects here. And you can see that, we give it as a bolus followed by continuous infusion, mainly because the half-life is so short there. Biggest things you're going to see with Precedex, though, is hypotension and bradycardia with higher doses. So you do want to watch their cardiovascular function to make sure that's not going to be too much. And so again, the choice of anesthetics is largely going to be based off of the location, the type of anesthetic that's going to be required, the depth of sedation that you need for that patient there, and then the anticipated length, right? If you have a good orthopedic surgeon, for a lot of these reductions of fractures, they can be done within 30 seconds, right? So I don't need a drug that's going to be lasting me 2 hours. So I can use something like ketamine. Has a short half-life. They'll be in and out within 20 minutes or so, and they should be up and ready to be discharged potentially, right? Also want to look at things like patient's condition, their age, and if they have previous experiences. Some people react poorly to certain agents, and they may react really well with other ones. So if they tell you that a really bad reaction to ketamine before, it's probably something related to that dysphoric reaction. I don't want to poke the bear again, so give them something different, right? And then also think about things like available equipment. Like obviously you need to be able to breathe for these patients in case they develop apnea or respiratory depression. So usually having someone like your respiratory therapist around, having the ability to intubate a patient, appropriate equipment, all of that is very, very important to have there. And frequently, it's going to come down to whatever the person who's providing the anesthesia, whether it be the ER doc, whether it be the anesthesiologist, what they prefer, and along with the patient condition is very important. So, I think I'm going to cut it off there. We're almost caught back up, but I'm going to leave the local anesthetics for next time. And hard to believe we're almost done with this class. We have a couple meetings left, which is surprising. But yeah, so do you guys have any questions before I let you all go for the day? On the board. I've been used for procedural sedations, meaning I just kind of drone at them for 2 hours, and that usually puts them to sleep. Or they just put on some of my YouTube videos, and just usually can knock anyone out pretty quickly there. So, questions at all? All right. Well, otherwise, you guys are free to go, but I'll stay on for another minute or two to see if anyone pops up with a question. See anything? So I will see you guys next week. Have a good one.